Yeah, thank you very much for introducing the GLOHRA Academy Series, and I'm happy to be here. Thank you for the great turnout and for being here on this evening. So I'm a professor at the Institute of Social and Cultural Anthropology at Freie Universität Berlin, and I'm leading a research area there, which is called Medical Anthropology, Global Health. And I'm just jumping right into the presentation right away, and I look forward to your questions and the discussion later on. So, well, next slide. Yes, yeah, thank you. Anthropologists have long been involved in the study of health and medicine, and medical anthropology has been established as a subdiscipline since the 1960s. In particular, medical anthropologists have helped to understand culturally shaped health behaviors, but also the unequal distribution of the burden of disease and death around the world. They have also applied these insights to the fields of international health and health development, which were prominent in both development work and health research until the early 2000s. But while the discipline has a long tradition of researching and teaching about medical and health issues, the field of global health has raised new questions. As Emily Yates Durr, a US anthropologist, medical anthropologist, notes, the relationship between anthropology and global health is thereby an uneasy one. So while anthropologists welcome the growing attention to the global connectedness of diseases, they also witness frictions between the methods, orientations, and interests of different scholars and practitioners in the overlapping fields of global health and anthropology. So in this talk, I would like to ask two questions. Next. Yeah. What does global health mean from the perspective of critical medical anthropology? And second, what theoretical and methodological insights can critical medical anthropology offer to global health research and practice? In the first part of the presentation, I provide an insight into my ethnographic research on HIV/AIDS in Tanzania, which I conducted from the mid-1990s to the early 2010s. This research covered different aspects of how people responded to HIV-related challenges in their lives and exemplifies some of the core approaches of critical medical anthropology in the context of global health. In the second part of the talk, I will turn to my more recent research activities on the COVID-19 pandemic. And I will use these examples to outline what critical medical anthropology has to offer to the field of global health in terms of a collaborative and decolonial approach to research and practice. So during my fieldwork on HIV/AIDS in Tanzania, I focused on two locations. The first was a rural area on Lake Victoria, close to the Kenyan border. The second was Dar es Salaam, Tanzania's cultural and economic center. My research involved various types of qualitative interviews, but mostly participant observation, that is, becoming part of people's everyday lives over a long period of time. I started by focusing on the sexual selves of young people in rural areas. Next. In the mid-1990s, Tanzania had just made the transition from a socialist country to a multi-party democracy and was undergoing far-reaching economic reforms parallel to the rapid spread of the HIV epidemic. In this context, I ask how young people's perceptions of sexuality were linked to a discourse on changing gender relations and how they contrasted these changes with what they perceived as traditional forms of love and sexuality. Three findings stood out. First, young men and women placed a high value on early marriage, which they believed was ideally arranged by their families. While they did have individually chosen sexual relationships, they valued them much less, as their goal in life was to have an arranged marriage. Secondly, men's needs were usually prioritized over women's. This preference was expressed in relation to the use of condom, which both men and women disliked, the question of pregnancy, which was valued as a sign of fertility, and the question of whether a young couple should have sexual relations at all, which was ultimately decided by young men. And thirdly, my interlocutors were very uncertain about how to discuss intimate matters with each other as there was no explicit talk about sexuality, either in public or the family. This impression was conveyed by the poster on the left, in which a young couple asks, "If our parents don't talk to us about sexuality, who will?" All of these perceptions contrasted sharply with the notions of modern or true or romantic love, which were promoted by some sections of the media and mostly secular NGOs at the time. This kind of communication about sexuality, in which sexual partners were said to communicate with each other in a trusting and equal way, was considered unrealistic by my interlocutors, who said that young women were subject to strong economic pressures and relied on gifts from their boyfriends. Such a shift towards modern and equal sexual relationships was also discouraged by families, schools, and churches, leaving young people caught in a web of conflicting norms, expectations, and desires. In this context, anthropology provides two important insights for global health research and practice. First, young people are struggling to navigate the complex field of an emerging epidemic transmitted through sexual relations and how to make active and confident choices. And second, in the context of my research, these choices were always problematic, either in terms of protecting young people's own health or becoming a person morally respected by their partners, families, peers, etc. Next, please. The second theme of my research was the dynamics of care and support in the context of HIV/AIDS related illness and dying. At the time of my research, the main responsibility for the care and support of people living with HIV/AIDS lay with families. There were no NGOs providing care and support in the rural areas, and the only hospital available was a private one where clients had to pay. In these circumstances, family care and support was characterized by the following dynamics. The first was the strong stigma of HIV/AIDS, which prevented any open discussion of the illness at the time. Second, the search for different types of healing and treatment options, for example, among traditional healers and Pentecostal churches. And third, the widespread conflicts over care and support in a context of scarce resources, which raised very pragmatic questions such as who was responsible for caring for patients, who provided resources for their treatment, who was responsible for burying deceased relatives. All these dynamics severely affected young unmarried women who did not yet have a husband and their own home. They were the ones who fell through the safety net of patrilineal kinship networks and whose bodies became sites of contestation over burial obligations after their death. Such gaps in kinship-based solidarity networks were partly filled in the cities by NGOs and neo-Pentecostal churches, which provided care and support to vulnerable groups. However, when people became seriously ill, they tended to return to their rural homes. And even in the cities, families made all the relevant decisions about the care of the terminally ill or the burial of the deceased. So, what can anthropology contribute to global health in settings of care? First, critical medical anthropology helps to understand how people experience and engage with very different sources of care during their illness trajectories, families, NGOs, and churches, among others. Second, it shows how multiple care relations and the discourses, values, and practices that define them emerge under very specific structural conditions and in increasingly fragmented healthcare systems. And third, it shows how families and patients struggle to reconcile the advice and services of transnational NGOs and public health campaigns with locally existing ways of caring, dying, and burying. Next, please. Finally, my research on HIV/AIDS in Tanzania included a joint project with Dominic Mattes on the introduction of antiretroviral therapy, the largest health intervention in the history of the African continent until today. The research was conducted in Tanga, a major city in the northeast of Tanzania, and it showed that a sense of normalcy was emerging in relation to what was now an increasingly chronic disease. This was reflected in a public health approach based on regular drug use, ideally supported by a buddy system. On the other hand, however, the stigma associated with HIV infection remained, and people often sought to hide their drug use from their families and partners. Others continued to seek alternative treatment and healing from healers, churches, and mosques. Against this background, treatment programs in hospitals and clinics aimed to strengthen patient self-discipline. Health workers offered advice on all health-related aspects of their clients' lives, including nutrition and reproductive and sexual behavior. Patients in turn struggled to reconcile public health advice with lack of resources, for example, when they had no money for buying healthy food, and conflicting social and moral obligations, for example, when they wanted to have children despite the associated health risks. So what do all these examples mean for the questions I outlined at the beginning of this talk? Three aspects are relevant for a critical medical anthropology perspective on global health research and practice. First, the examples illustrate that people's ways of coping with health threats and illness experience involve issues that go far beyond medically or politically defined health advice. The anthropological focus on social and cultural contexts reveals how individuals and communities deal with HIV/AIDS related prevention messages and care expectations. It also shows gendered and age-specific relations of care and support in increasingly deregulated health systems and in times of demographic and economic disruption. Furthermore, anthropologists explore how people often have to negotiate therapeutic guidelines against their own reproductive priorities or those of their families and partners, and what role alternative healing options and/or the struggle for a life in dignity in the face of stigmatization play in this context. In all these respects, people's agency, that is, their capacity to reflect and act on emerging life challenges and to potentially transform their life worlds according to their own needs, is an important category of anthropological research. People's choices and practices are often at odds with the information they receive from medical professionals and/or public health campaigns. Second, the field of global health is designed, to find and implement solutions to emerging health problems in the most efficient and usually the fastest way possible. The sense of urgency was also present during my fieldwork on HIV/AIDS in Tanzania. While NGO experts and policymakers find my research relevant, they also questioned the long-term approach of ethnographic fieldwork when people are actually dying, as they said. Anthropological research is necessarily slow as it traces people's positions on sensitive issues such as sexuality, burials, or evolving care arrangements in resource-poor settings. Moreover, as Stacy Pick has argued, listening to and sitting with people in the field is the only ethical way to make visible the perspectives of those whose needs are often taken for granted in global health interventions. It is therefore fair to ask, is it not highly relevant to the development of effective interventions to have more detailed knowledge of the social, cultural, and political processes that shape people's ability or their inability to adapt their behavior to local, national, and international health interventions? Third, medical anthropologists focus not only on people's individual experiences and behaviors in relation to particular health challenges, but also on how their positions are linked to larger political economic forces and healthcare developments. In my research on HIV/AIDS in Tanzania in the early 2000s, an individual person's inability to fulfill his or her care obligations towards a dying relative was often due to the overburdening of families who received little or no support from state institutions or NGOs. Similarly, young people's refusal to use condoms was not simply a matter of ignorance, but rather the result of moral, economic, and social pressures, where young women in particular had little room for maneuver to protect their own health. In all these respects, anthropological research can expose and critique the way in which global health policies and funding interact with national and local healthcare systems. This includes not only people's access to and exclusion from healthcare, but also the detrimental effects of neoliberal reforms on healthcare provision in chronically underfunded countries such as Tanzania. Before returning to these aspects at the end of this talk, I would like to briefly present my recent research activities in relation to the COVID-19 pandemic, which illustrate additional insights that critical medical anthropology offers in relation to global health. As the COVID-19 pandemic began to spread across the globe in the early 2020, it became impossible to conduct anthropological fieldwork in situ. Together with other colleagues, we therefore started a collaborative blog series aimed at witnessing the lived social and cultural realities of the pandemic over time. Next. Since March 2020, we have published 39 blog posts with different thematic and geographical foci, including contributions in and from Europe and the so-called Global South. Contributors included both students and advanced researchers. Blog posts were written in German and English and included texts, photo essays, films, and audio clips. Next. Some of the blog's recurring themes were individual and collective experiences of different forms of lockdown, how public health interventions were shaped by specific political systems, the impact of social, political, and economic inequalities on vulnerable groups such as refugees, a critical appraisal of the language, terminologies, and discourses used in public health campaigns, site-specific dynamics of solidarity and blame, and the rumors and mistrust that arose around pandemic interventions, including vaccination. Next. Let me briefly describe the first post in the series by Brandan Huygen, a South African PhD student doing research on crime in Cape Town at the time who had just returned to Berlin when the pandemic hit Germany in March 2020. When he and other international students he lived with noticed the German government's initial reluctance to respond to the pandemic, he decided to return to his home in Cape Town. In his piece, he showed how Europe and Germany were seen as risk zones from a South African perspective, reversing established perceptions of potential contamination in the global health order. He also contrasted a more repressive approach to pandemic governance in South Africa with the, as he perceived it, more relaxed response in Germany, and asked how the sometimes violent enforcement of lockdowns was perceived by the South African population. In particular, he attributed people's general acceptance of harsh restrictions on mobility to fear of the state, but also to experience with previous epidemics such as HIV/AIDS. While the COVID-19 pandemic has not fully ended, the enormous impact of the disease across the globe has confirmed some of the insights that medical anthropologists have been formulating about the field in recent years. Next. First, the emergence of new viruses around the world has led to an increased focus on pandemic preparedness and response structures in context of global health. As a result of mostly regional epidemics such as MERS, SARS, or Ebola, massive public and private investments have been made in pandemic preparedness infrastructures with the aim of detecting new pathogens early and tracking disease outbreaks around the world. Despite these efforts, however, the European response to the COVID-19 outbreak in particular demonstrated a striking degree of unpreparedness, and global health researchers have yet to learn the lessons of this highly influential event for future pandemic outbreaks. From an anthropological perspective, the real-time witnessing of COVID-19 in a globally comparative perspective highlights the need to pay close attention to the similar and the specific ways in which societies and policies responded to the outbreak. These responses have been shaped by political and economic conditions, as well as cultural values, for example, regarding solidarity or individual freedom, combined with people's desires and needs to maintain social and emotional ties in times of crisis. In addition, responses to COVID-19 depended on society's experience of previous epidemics. In particular, Asian and African countries were quick to implement health protection measures, which also included the grassroots mobilization of solidarity networks, while responses in Europe could not rely on pre-established agreements on how to deal with a crisis of this magnitude. In this context of pandemic learning, the anthropological witnessing of a pandemic outbreak needs to take place in collaboration between Global South and Global North scholars in order to recenter global health perspectives. In fact, COVID-19 could have been a unique opportunity for such collaboration and mutual learning, but both political and scientific debates were limited by strongly national perspectives. Next. Second, in classical approaches to international health, the main sites and objects of health research and intervention have tended to be located in the Global South, while the relevant expertise and technologies for dealing with health problems have been generated in the Global North. The COVID-19 pandemic has shown that pandemic disease is no longer the exclusive experience of the non-Western others. In fact, COVID-19 affected European and North American societies on an unprecedented scale, demonstrating that these regions are equally vulnerable to the health risks of an interconnected world. It is crucial for the field of global health to rethink its long-held assumptions about how the world is organized in terms of health and well-being, assumptions that tend to be based on long-standing colonial and post-colonial patterns. As Todd Myers and Nancy Rose Hunt have argued, urban contexts in the US and the Democratic Republic of Congo today, for instance, have much in common in terms of failing medical and other infrastructure, the increasing number of public health emergencies, and the growing presence of poverty. A decolonial perspective examines such developments in relation to each other, thus moving beyond US and Eurocentric perspectives on global health. As Wenzel Geisler and Ferdinand Okwaro have argued, new forms of collaboration in global health research are needed that involve equitable transnational and transcontinental partnerships between researchers, communities, and other health professionals from the outset. Next. I would just like to briefly mention the transnational research collaboration in which I'm currently involved with colleagues from South Africa, South Korea, the Democratic Republic of Congo, and Germany. In this project, funded by the Volkswagen Foundation, we are investigating the unequal impact of mobility restrictions on specific social groups in the four settings. We are also exploring the affective and emotional embodiment of this impact and how this emotional embodiment may shape people's orientations towards a future health crisis. In all these respects, we seek to establish a model of collaboration in which we are all involved in the formulation of research questions and methodologies, and in the interpretation of findings in terms of similarities and differences across our different research sites. But let me come to the conclusion now. In the inter- and transdisciplinary field of global health, clearly defined agendas provide guidance on the most pressing issues to be addressed in research and practice. At the same time, however, these global health frameworks tell us little about how doing global health actually works, or about the conflicts and frictions implicit in these dynamics. Who defines which health problems are addressed by whom, and for what reasons? Whose perspectives are involved in the design and implementation of research and health interventions in a context where most funding comes from the global north? Critical medical anthropology challenges us to consistently incorporate the usually highly diverse perspectives of the communities of our research and intervention sites. It also calls for a rethinking of the conceptual and methodological underpinnings of global health, and the formation of more equitable partnerships in all areas of our work. In particular, critical medical anthropology asks us to focus on the following aspects in global health research, as I have shown: context and agency in community responses to health challenges, the slowness of ethnographic research and its political and ethical relevance, political economies and power relations, and collaborative and decolonial approaches. The call for a critical medical anthropology perspective on global health does not mean that anthropologists have the solution to all these questions and challenges, but critical medical anthropology can help to think more, to think us, help us to think more about diverse and equitable forms of global health research and practice in an interconnected and post-colonial world order. And the next slide has some select readings. And then I thank you very much for your attention. I look forward to your questions